Good
Good
evening.
everyone. Today my topic is on anesthesia for non-cardiac surgery in patients with congenital heart disease patients. Congenital heart disease are the most common birth defects occurring in approximately 16,000 live births. Majority of the untreated patients with congenital heart disease die in infancy or childhood. 50 to 25% survive into adulthood. Congenital heart disease can be functionally classified into acyanotic congenital heart disease, that is left to right shunt. Example, ASD, VSD, patent ductus arteriosus. Here, the oxygenated blood from the left atrium, left ventricle, aorta transmits into the right atrium or right ventricle or pulmonary artery. Lung receives all the deoxygenated blood from the systemic venous return and the volume of fully oxygenated blood that is shunted through the defect. This in turn leads to volume overload of the cardiovascular chamber depending on the location of the defect. If the defect is large and non-restrictive, there is increase in both flow and transmission of near systemic pressure to the pulmonary vascular blood. This in turn leads to irreversible changes in the pulmonary vascular bed, increased pulmonary vascular resistance associated with pulmonary artery hypertension. If the pulmonary artery pressure is at systemic level, there may be shunt reversal or bidirectional shunting at the level of defect. Other obstructive lesions like congenital aortic stenosis, congenital pulmonary stenosis, coarctation of aorta comes under acyanotic congenital heart disease. Cyanotic congenital heart disease. Here, the anatomical heart defects that produce a limitation in the blood flow or resulting in the mixing of oxygenated and deoxygenated blood. This in turn leads to decreased blood oxygen content and cyanosis. Example, tetralogy of Fallot, transposition of great arteries, single ventricle circulation, total anomalous pulmonary action, a hypoplastic left heart syndrome. Physiologically, the congenital heart disease can be classified into one of the three physiological circulations. In normal or series circulation, the deoxygenated blood returns to the right side of the heart, travels through the lungs, through the pulmonary arteries, and oxygenated blood returns to the left side of the heart and travels via the aorta to the rest of the body. In balance or parallel circulation, the two circulations are not separated. That is, the systemic and pulmonary circulations are not separated. Oxygenated and deoxygenated blood completely mix, and the amount of pulmonary blood flow and systemic blood flow is determined by the difference between the pulmonary vascular resistance, systemic vascular resistance, or presence of any obstructive lesion. The volume of pulmonary blood flow to the systemic blood flow is expressed as QP is to QS ratio. A QP of QS of 2:1 means twice as much of pulmonary blood flow as systemic blood flow. Increased pulmonary blood flow causes heart failure, pulmonary congestion, respiratory infection, failure through time, damage to the pulmonary arteries over time. A low QP by QS result in cyanosis. A third category is single ventricle circulation. In these lesions, only one functional ventricle, which prevents the child from undergoing a biventricular repair to form a normal or series circulation. Instead, palliative procedures are performed to allow the one ventricle to pump the blood in series through the aorta to the blood, and then the blood then flows down the pressure gradient through the lungs via the pulmonary arteries. Pulmonary blood flow is dependent on the transpulmonary pressure gradient. So, the long-term sequelae of congenital heart disease that increase the perioperative risk are myocardial dysfunction, including heart failure and cardiomyopathy, arrhythmias. Mostly ventricular ectopics are more common, which leads to more than 30% of death in patients with congenital heart disease, cyanosis, pulmonary hypertension. Patients who had a definitive repair of simple lesions, for example, ASD, VSD, are unlikely to have a long-term sequelae. Patients with more complex repairs, for example, valve repair or single ventricle palliations, are more likely to have a long-term sequelae. Risk stratification. This stratification of patients with congenital heart disease for non-cardiac surgery is complicated because of the heterogeneity of cardiac lesions and surgical procedures. It involves consideration of three factors: assessment of CHG complexity. Based on ACS NSQAP criteria, based on ACS NSQAP, CHG patients are classified based on the following definitions. minor, it involves unrepaired asymptomatic acyanotic congenital heart disease and can be on medication, and repaired congenital heart disease with no residual hemodynamic abnormalities requiring no medication. Major is unrepaired symptomatic acyanotic congenital heart disease and repaired cyanotic heart disease with residual hemodynamic abnormalities. Severe is unrepaired cyanotic heart disease, pulmonary hypertension, ventricular dysfunction requiring medication, and patient listed for heart transplant. There were increase in mortality and morbidity for patients with major and severe congenital heart disease. Now we come into the identification of any long-term sequelae or high-risk features, that is the red flags for congenital heart disease, which increase the risk for non-cardiac surgery. They include single ventricle circulation, parallel circulation, aortic stenosis, cardiomyopathy, heart failure, arrhythmias, cyanosis, pulmonary hypertension, age less than 2 years, and ASA more than 4. Assessment of surgical risk. The surgical procedure can be determined as major or minor. The mortality risk in patients with congenital heart disease is 5 times higher for major versus minor. The presence of one of the following places the surgery in major category, that is emergency surgery, intrathoracic surgery, intraperitoneal surgery, vascular reconstructive surgery, orthopedic and neurosurgical procedure with potential risk of blood loss. Coming to the preoperative assessment of congenital heart disease should begin with physiological classification, risk assessment. Peri-op evaluation involves assessment of the functional status of the child, any history of recent RTA, room mass saturation, BP readings, labs like hemoglobin, PT-INR, APTT, LFT, and RFT. Cardiac evaluation includes recent ECG, echocardiography, and cardiologist visit. Determine whether the patient requires any infective endocarditis prophylaxis. Infective endocarditis prophylaxis is recommended in patients with a history of previous infective endocarditis, cyanotic congenital heart disease, and patient with prosthetic valves or valve repair. So anesthetic consideration, it involves a multidisciplinary approach that should be cardiologist, interventional cardiologist, and cardiac ICU care for the patient. It should be done planned early in the day so that adequate assistance is available. Adequate knowledge about the pathophysiology of the congenital heart disease should be known to the anesthetist. So based on this, 3 risk stratification, they can be classified into high risk, intermediate risk, or low risk. High risk is when the ACS, NSQAP, CHG classification is severe and there is presence of one or more long-term sequelae and the surgical risk is a major surgery. Intermediate risk is when the patients have a NSQAP, CHG classification major and presence of major surgery. There is no need for any presence of any high-risk long-term sequelae. Low risk is when there is even it is a minor surgery and the NSQIP criteria is minor. So before planning for anesthesia in patient with congenital heart disease for non-cardiac surgery, we should look into the CHG physiological classification, NSQIP criteria, presence of any long-term or high-risk feature, surgical risk, and the overall risk should be assessed. The anesthesia should be planned according to that. For elective surgery, high-risk patients should be transferred to a specialty center with adequate cardiac intensive care and interventional cardiologist presence. For intermediate risk, there should be perioperative discussion with the specialty center to determine an appropriate location of care. In emergency cases, low risk should be managed where they are. For intermediate and high-risk patient, discussion should occur with the specialty center if time allows. Anesthesia, patient with CHG can be safely managed with general anesthesia, neuraxial anesthesia, or regional anesthesia, and even under sedation. So, in designing an anesthesia plan, begin with your preferred anesthetic plan for specific procedure. Consider how that plan would affect the hemodynamic goals of their patient. Will the patient be able to maintain adequate cardiac output and oxygen delivery with that plan? In patient with balance or parallel circulation, how the anesthetic plan will change the QP by QS. If the cardiac output is not sufficient during the procedure, what will be the best initial management? That is the fluid administration or vasoconstriction item that should be assessed. Now we will look into the anesthetic agents and their hemodynamic effects. Sevoflurane, avoid prolonged exposure to high concentration, as in high doses, it decreases the systemic vascular resistance and contractility. So, at low doses, there is no change in systemic vascular resistance and contractility. So expect a slow induction in patients with myocardial dysfunction. Propofol, at high doses, it decreases the systemic vascular resistance. So this decreased systemic vascular resistance will increase the shunt and should be used slowly and carefully in high-risk patients. Ketamine and etomidate, these are effective anesthetic agents with virtually no hemodynamic effects. Opioids is cardiovascularly very stable, even in high doses, but should be used in limited, but its use is limited in non-intensive care patients due to respiratory depression. Benzodiazepines and dexmedetomidine, they are used as adjuvant to reduce the concentration of inhalation or intravenous agent. Now we will look into the factors affecting systemic vascular resistance and peripheral vascular resistance and pulmonary vascular resistance. Increased systemic vascular resistance is seen in hypothermia, sympathetic stimulation, example pain, and vasoconstrictors. Decreased systemic vascular resistance is seen in hyperthermia, sepsis, volatile agents, propofol, decreased hematocrit, spinal or epidural analgesia. Increased pulmonary vascular resistance is seen in hypoxia, hypercarbia, acidosis, increased intrathoracic pressure, atelectasis, increased hematocrit, hypothermia, and sympathetic stimulation. Decreased pulmonary vascular resistance is seen in supplemental oxygen administration, hypocarbia, alkalosis, decreased hematocrit. So, in conclusion, by understanding the physiology, anesthesia providers should use the most appropriate anesthetic agents to optimize the hemodynamics. This stratification of the patient allows for early identification of high-risk patient, as there is increased perioperative mortality and morbidity. Thank you, sir.
Very good. Got a very clear concept about the topic on congenital heart disease patient coming for non-cardiac surgery. This concern of this topic, can you tell me few cases or conditions which you can encounter in your practice or which may be kept in the exam, where a congenital heart disease patient may come for a non-cardiac surgery?
Tetralogy of Fallot, sir.
Tetralogy of Fallot patient coming for what surgery? It should not be in a corrective surgery for the heart. The topic is congenital heart disease patient coming for non-cardiac surgery. We are not trying to correct the tetralogy of Fallot.
Yes.
What your answer is right.
Yes.
What non-cardiac surgery these tetralogy of Fallot patients come for?
Emergency like appendicectomy, lap appendicectomy.
Excellent, very good. Okay. Any complication due to tetralogy of Fallot for which the patient may come for an quasi-emergency surgery? A patient who has known case of tetralogy of Fallot, who has grown up to say 5-6 years with the tetralogy of Fallot, suddenly becomes little drowsy, disoriented, vomiting, with signs of raised intracranial pressure. What complication of
abscess?
Brain abscess? Yes, it is one of the quasi-emergencies which can happen in a patient with tetralogy of Fallot. Okay. Any other infant cases less than 1 year coming for a non-cardiac surgery with a congenital heart disease which is very prevalent?
Torsion testis, sir.
Partial?
Torsion testis.
Testicular
torsion.
Recurrent URI for adenoidectomy, tonsillectomy.
No. Patient with the congenital heart disease diagnosed at birth, who may require surgery within 3 to 6 months of age. What is the commonest condition you come across?
Failure to thrive.
It's a facial anomaly.
The cleft lip, cleft palate, sir.
Cleft lip and cleft palate patient, usually what congenital the heart disease they have? What is the common
Often
congenital
58.
heart anomaly they are associated with? Ventricular septal defect, VSD. Okay, all patients who come with a cleft lip and cleft palate, do not forget to examine the heart in detail. At least 1 in 100 cases, you will be able to clinically diagnose a well-established ventricular septal defect with a harsh murmur or a soft murmur. If the murmur is very harsh, what does it mean? If the murmur is soft, what does it mean?
Systolic, pansystolic murmur will be a harsh murmur, sir.
No, that is the nature or duration of this murmur, but I am telling you about the quality of the murmur, the sound. If the murmur is harsh, like say,
The septal defect will
the
be large if it is a harsh
machinery
murmur.
harsh, will it be large or will it be very small?
Will be moderate, sir. If it is very small or it is very large, there won't be any murmur hurts.
A harsh murmur always indicates a small opening because the turbulence produced is more. Whereas a large opening, the resistance is very much less. The turbulence produced is very much less. So the murmur will be quite soft. So clinically itself, you can make a rough diagnosis of the size of the communication or the defect in the ventricle, between the ventricles, by the quality of the murmur. Okay. So these are all some of the common congenital anomalies for which patients from infant stage to adulthood can come for non-cardiac surgeries. And the most important difference in congenital cardiac diseases is it is not like a normal circulation where the venous blood comes to the right side of the heart through the SVC and IVC from the various parts of the body, enters the right atrium, goes through to the right ventricle through the tricuspid valve, then goes to the pulmonary circulation through the pulmonary artery, gets purified or oxygenated, comes to the left atrium by the pulmonary veins, and then goes to left ventricle through the mitral valve, and then gets ejected into the aorta for systemic distribution. This is impeded in congenital heart disease in the form of the communication between the left side and right side. Normally, the left side pressures being higher than the right side, flow will always be from left to right. So in these patients, because oxygenated blood is only mixing with the venous blood or deoxygenated blood, patients will be acyanotic. They don't exhibit cyanosis. On the contrary, if the right side pressures are high and there is a communication, the deoxygenated blood will come and mix with the partially oxygenated blood that is not fully oxygenated from the lungs, and patient will exhibit cyanosis right from birth or develop cyanosis within a few days of birth. Why a patient with tetralogy may not exhibit cyanosis at birth immediately?
Due to patent ductal sarcoidosis.
Excellent, because of the communication between the aorta and the pulmonary circulation through the patent ductus arteriosus, which will be functional up to what time after birth? It will be open and functional. The communication will still remain after birth.
2 weeks.
Yeah, 3 days to 2 weeks. But functional closure is supposed to occur within 72 hours, but anatomical or fibrotic closure of the communication will take 2 to 3 weeks. Okay, and they can reopen at any time. So patients who, once the communication gets closed, then patient will start exhibiting the cyanosis, and they are called as duct dependent and duct independent circulations. Okay? So the circulation which has isolated as in a normal circulation between the right and left side, what is the name of that circulation? You have a volume pumped out. Is it called parallel? The blood which is pumped from the right ventricle goes to the pulmonary circulation, reaches the left side and then goes to
Circulation, sir.
series. Yes, it goes in series. It is not parallel. Whereas if it is isolated from right and left, independently they are going, then it is called the parallel circulation. Okay? So these are the things that you have to basically understand about the congenital heart diseases. And if these patients come for surgery, first of all, the patients can come to you in three different type stages. First of all, they may not know that there is a heart disease at all. I have diagnosed many a times when the patient, one patient, adult patient who came for a mastoidectomy to me at the age of 60 because of chronic middle ear infection. I auscultated and found he had a pulmonary stenosis. The murmur was classical at the pulmonary area, and nobody has told him. He has grown up with that up to the age of 60, and then he was having no effort intolerance or any features. He was married, his daughter was married, he had a grandchild, and we came for a mastectomy. And by routine examination, I found that he had a pulmonary stenosis, and then went into a cardiologist. It was established. In those days, we didn't have even echo. So a clinical diagnosis of pulmonary stenosis was made. Because he had a compensated cardiac function, we could take up the patient for mastectomy and do it successfully and getting rid of that problem. Similarly, another case of VSD, actually the patient is a neighbor of mine. She was diagnosed with VSD during her first pregnancy when she went for a delivery. And she had a uncomplicated LSCS done because of slow progression of labor. Then she conceived second time. Second delivery also was under general anesthesia for LSCS. And now recently she developed a myocardial infarction and had 2 stents placed, all with the uncorrected VSD. And she is doing well now. So minor defects will not cause much of a problem. On the contrary, symptomatic defects producing obvious cyanosis, effort intolerance, repeated respiratory infections, or features of pulmonary overloading, all these patients will definitely seek ready for that and come to the doctor and they will be diagnosed. So you can have first category of patients with a congenital heart disease, asymptomatic totally, not diagnosed and diagnosed incidentally when they come for a non-cardiac surgery. They are all very safe patients because they have grown up without any problem. The second category, they have features or symptoms of the congenital heart disease and they seek treatment and they are either partially treated or fully treated. So the fully treated patients, they become almost like a normal patient and they are also safe category. It is only the partially treated or not treated patients who are symptomatic, they are the ones who are going to be problematic for you. So it is easier to identify these three categories. Patients with a congenital heart disease, totally asymptomatic. Patients with symptoms of congenital heart disease, treated. Patients with symptoms of congenital heart disease, not treated or partially treated. So these are the three categories you will come across. You have to make your plan of anesthesia to safeguard these patients without exaggerating the features of this congenital heart disease and make them go back as is where is condition without complicating them more. Okay, that is what the aim of this particular topic is. And Muthupriya has done a very good preparation of this topic. So I'll just share my screen with you to show the